And welcome to this pre-conference session for IHEA 2023 in Cape Town. I'm Paula Logelli. I also just coincidentally happen to be the co-chair of the conference, but that's not my role here today. I'm the organizer of this pre-congress session as a member of the Europol group. I want to apologise because I'm going to be doing this a lot. And in speaking, I suspect for the rest of the conference is also going to be doing this a lot, but maybe we can work out the logistics later. Australia. Where am I pointing this? Right, excellent. Which one was that? Which direction? Okay, so we're going to start off with some welcome and some introductions, so you can get to know the people in the room, including the speakers. And then I'm going to give you a little bit of a background to the EQ-5D, which is the main instrument as part of the Europol suite of instruments. And then we'll have so that'll be about 10 minutes, and then we're going to spend 20 minutes each on three presentations looking at things that use qual, except definitely. So the hot qual, the heavy qual, the EQ-5D. You never had a chance for a coffee break, and I think someone's going to tell me what the coffee is for that break. Maybe not, maybe of us. Just follow coffee. And then we'll come back and we'll start some discussions and have some Q&As. I think part of this will be a long journey from, as well as for us, particularly because in the last half an hour, we'll actually talk about research opportunities. And so I will cover some of that at the end and also after the discussion. So as well as an organisation that owns the instrument, we also have research funding that's available for individuals to apply for so we can do research on the instrument. Okay. Now, so if I was in New Zealand, I would be starting with Whakataki, which is a kind of like a proverb. It's probably not quite appropriate here, and we also don't need to hear us pronounce it. So I actually looked up a couple of different African proverbs, and I quite like this one, which is knowledge is like a garden. If it's not cultivated, it cannot be harvested. And so if we don't make the effort to acquire knowledge, then we don't expect to have it. Or if you don't put that knowledge you have to use, then you can't expect to gain anything from it. And so I hope what you get today and this next afternoon is that knowledge. And what I'd love to see is that knowledge transmission more after this session when you start putting that knowledge into practice. And it may not be that you use the EQ-5D, and that's okay. I'm not about to try and convince you to manage EQ-5D user, but it may be just that this is some different types of health economics research that happens kind of in the population health space. So let's do some quick introductions. So to ask you to, actually I don't need to. About the logistics of this, I can pass you the microphone. So I'll just say quickly, so I'm Paula Logelli, Professor of Health Economics at the University of Auckland, which I can tell you feels like it's wrong on the way today after arriving yesterday. I've had a career in lots of different places and spent time in lots of different continents. I'm a member of the Europol group. I'm a member of the health and what is it called? Population and Health Systems working group of the Europol group. So I'm moderating the session, and I am presenting on the Europol and the EQ-5D. Trudy, you want to do a quick introduction? Right. No, is it? No. No.
Hello, I'm Trudy Sullivan. I'm a health economist and associate professor at the Department of Preventive and Social Medicine at the University of Otago in New Zealand. And I'm a member of the Europol group, and I'll explain when I have my presentation some of the work that I do within that. So I'll just leave it there for now.
Thanks. Prepare.
Hi everyone, I'm Kirtan Sinha. I'm an associate professor of economics at Macquarie University. Very pleased to be part of this team here to talk about the EQ-5D. And if you want to connect, let's chat later. Hello everyone, I'm Grace Scott, and I'm not a health economist. It's okay. And I've been a member of the Eurocal Group since 2018.
So you might tell from that accent that Jules is the only one that's not going to be jet lagged as well. Jules is a local to Cape Town. I've got her involvement in this session. Now, I also wanted to make sure that you also got to meet somebody new, right? Why not start now? You know, a lot of whole people in the next 5 days. So please, could you turn to, and also if you're sitting in the back, you're very welcome to come up to the front. I appreciate you might want to social distance still. There are some tables here, which I always find are much more enjoyable to sit at. So if anyone wants to now shuffle the moving, do move now. Or you can just not look at me while I'm staring at you. That's fine. Take that time to just turn to, say, the person on your left. I don't think that's going to work for the person that's got no one on there. And just say hello, who you are, a little bit of an introduction. And if you're online on Zoom, put something in the chat. Thank you. I really don't want to stop you from talking. So this is the most important thing, I think, about being in a face-to-face Congress. Front, come on. Just sit in front. I think it's time keeping. So I think that's my most of my job today. So let's try and keep it. That's time keeping. Okay, so I'm going to get some before this. So that's 1+, right? Before we learn about EQ-5D. Should I say, can I give a show of hands on who has used the EQ-5D before? Okay, fabulous, right. I might be teaching a little bit of suck eggs, which hopefully is a translation phrase that you know, and otherwise I can explain it to you later. What if I'm bumping this again? Above my heels? I'm sure I'm not. I'm sure Castro has just seen me put my hand up and just spoiling them. And there we go. Okay, so let me tell you a little bit something about the group. This is really I'm still on the Shabogi. So before I was a member of the group, I actually thought it was a group that had a secret handshake. So I'm going really off script now. But I'm really interested to understand what, there's an instrument which many of you know has got 5 questions in this kind of this thermometer. And what could they possibly meet about and how exciting the meeting to be? And I truly and for a long time. But I remember my first meeting. It was almost like one of those things you see on TV where this didn't happen, but in parliaments where shoes get thrown. It was actually kind of interesting to know how much academic debate happens. And this, it was actually at that meeting I want to be a member of this group because it was such academic debate within the group. But actually, I think it's really nice that we can actually go outside and actually still feel that we can debate and critique and making sure that we're trying to measure health and quality of life by doing it with these instruments. So it started back in 1987, which certainly none of us were at that first meeting. And the name was supporting this instrument that we evaluate assess and evaluate across the states. And it came up the first, I think it was 14, at that first meeting, European focused. That's the one thing. So, progress today, right? We've got 4 females speaking to us now. And actually, it's much more diverse now than it ever was before, which I think is just a reflection on actually, it's a great reflection of the theme of this conference, right? We're not so diverse. And what they call is EQ-5D. It's got a little asterisk there. This is actually a paper that some members of it has published. So EQ-5D is not an abbreviation. So some of them might be guilty of this. And I'm guilty of this because I'm challenged. So it comes back and says, can you provide the name in full? So the name in full is not the EQ-5D instrument. The name in full is just the EQ-5D. So it's not an abbreviation, which is a bit confusing sometimes. And so it's a global network. We have 150 members now, maybe since these slides were created a few months ago. It's based on the conditions based on evidence. And it has attached to it this research foundation, which is a not-for-profit organisation which provides research funding. So the instrument itself, we'll speak about this in the second part after the coffee break. Style, you have to, if you're a pharmaceutical company, you have to pay for these instruments. If you're an academic researcher, you don't. But the money generated by private institutions paying to use the instrument means that the funding is available for individuals to do research, to fund research on the instrument. So it's kind of quite a neat one policy scheme that also translates something. And so then the vision of the group is to help the decisions about health and healthcare by developing and promoting the use of instruments. And we have a mission on being kind of leaders in the space, fostering and supporting international communities, and ensuring access to good kind of research expertise, and also particularly now supporting early career researchers. So we have quite a range of researchers that we sponsor. And I should also say, so congratulations if you're here, we did sponsor some resource constrained, not sure the right word, in the country, researchers to attend this meeting as well. So actually, it's all about growing. As interesting as I am to listen to showing that you understand my accent, nobody really wants to listen to someone else. I've just said it, schools are old, and family I know because I've been to, but you don't want to listen to me. I know that the next stage of how economics goes and where health outcomes goes is actually people that are good with family. And everything to support that and what's becoming a more secure environment in the research space. So I love that. I feel like I've got this out. And so this is kind of like so we've got association on the one arm, and then the research foundation, which is what funds our research. And then there are these kind of groups. So really in the is the population health systems running which one and so many people probably might know EQ-5D as instrument in the journals if you want to generate ability adjusted life years. We don't often do this, of course, in the population and health systems working group. We're much more interested in just the instrument as a population health. And so what we try and do is initiate requests for funding and proposals. How the instrument can measure health systems and other non-health systems kind of performance, and we look at applications in that space. And we look at and try to promote large-scale applications, of which you're going to see through presentations kind of in that space today. And so just an example, I've returned after a few years away, 22, 23 years away. And despite the fact that Trudy and I are both in New Zealand and 2 other members in New Zealand, and health survey, New Zealand health survey, so the main health survey combination doesn't include the value of insurance. I'm trying to change that, and as a student, so we're having conversations to see if we can introduce it into a large national level health survey. It's, for example, in the standard language. And then I think once you understand, I mean, I guess that sort of standards is once you understand the health of the population, that's kind of interesting. So we can see how pandemics affect health, we can see how other shocks affect health, we can look at individuals across the the old, across social demographics. And then, of course, the fact that we often use the instrument in HCA means we can also understand, well, that population that they did this clinical trial on, how similar or different are they from the population of the country. So there's got some benefits for having it in these kind of large scale applications. Okay, so it's been the most popular, and I'm not saying it because I'm paid to say that. But there's actually evidence that this one is the most popular measurement of outcomes. It's short and simple, which is I always find that when we have collaborations, that we're only asking for one page or 2 sides of a page, or just talking now just before this, we're asking for 3 questions in a visual analog scale, 5 questions in a visual analog scale. Means it's into surveys, and it measures health in terms of 5 dimensions. And so we have the original measure, which was just known as the EQ-5D back in the day. We decided that we should expand it and the validity and sensitivity and create 5 levels. So we named the old one. It's kind of like Prince, as I call Prince. And I'll probably just use an example of a pop star that half the millions ways to want to understand who it is. Is Prince still called Prince? Yeah, formerly known as Prince. At some point, it was a symbol, I think. If my analogies get worse, by the way. And so it was the EQ-5D, the 3 ones called the EQ-5D, the 5 ones called the EQ-5D 5-hour. We have the EQ-5D-Y. We're trying to swap the segment developing the EQ-5D, and we're going to get this right. So we're going to truly Y 5-hour. Don't know why the Y is not at the ends, because in the middle for some reason. And then we also have a station, which is known called the EQ-HWB. So there's health and well-being. And it's and kind of social
space as well. And to promote it, there is a session at this conference where somebody is working on that. Spare's going to be presenting some work on that. So it's not just the EQ-5D kind of have this suite of instruments. And we also look at things like bolt-ons as well. So we've had some critique that maybe 5 questions is not enough. Maybe if you've got hearing or reading, and there are some bolt-on questions that can be used. So it's been registered in more than 17,000 studies, which just goes to show it's a very rigorous approach to trying to access instruments. But I think that's great because then we know stats like this as in the instrument is being used. And I think, whereas most people think it's part of clinical trials, and of course, it's not just about clinical trials. It's got amazing value in population health surveys. It's got value in patient-reported outcomes from space. We use it as a clinical decision aid, and even kind of large registries as well, disease registries. So it's been used from Afghanistan to Zimbabwe, and there's many different languages and translations, although I was going to be talking about that as well. And lots of different things, but still new. So just to promote another session I want to go to, which is my session on short day out when it's 7 days today. I have another session on Tuesday morning, and that's looking at I'm looking at the long COVID registry. So long COVID disease. I'm going to start on this EQ-5D. I have a student who says, looking through papers, and people are saying it's a valid measure of health for long COVID, but it's not, because I've only had long COVID as a disease for the last 3 hours. So there's a lot of research that's done just to show maybe what does and doesn't necessarily have a disease. And then, of course, it's used in health systems. So this picture over the side, which no one can read because the font is way too small, is a graphic from a colleague's paper who does a lot of work in this kind of patient decision aid sort of space. So for a clinician, ask patients to fill in the EQ-5D. Enough patients are filling in the EQ-5D, so we can start comparing patients against each other, and then you can say a similar patient who had similar profile as you, who chose X treatment, went on to have this experience. That's like really useful information that in the space where now we want more informed patients when it comes to making patient choice space. So that's that. Any quick questions? I'm going to check my time. I'm 4 minutes over already. See, I told you I was bad at this. Any quick questions? EQ-5D? Your introduction? If not, I'm treating. Are you getting the sound part is terrible? That's only that somebody on the side you. Okay. Come on again. So I'm about the study and specifically about the system of scoping review of population and health related quality of life. People because I thought I'd see it right down on the command. So I'll introduce myself. I'm a economist and I'm based in Otago in New Zealand, and I've been the 5 times tour when we at Christmas time and going to a swimming hole. So I just find that something to see. I'll start with just some of the things I do. So these things potentially 3,000 states. and to get values for each of those health states. That's what this study was about. And so we go out New Zealand online discrete choice experience survey, and we ended up with 2,468 participants to get values on each one of those health states. And then that we actually look at more in New Zealand to get international surveys. So it's been used by the Extent Compensation Corporation, and we are currently talking to the New Zealand Health and Safety Commission, and it's possible we can put it into a national survey, perhaps through general practice, so we can collect that data. But I guess what I should say, or I want to say here, and whatever studies we do, is what's really important is before we decide what we want to do, is what we're going to do with it. And so it can be really easy to create a study or a survey. This is really great to come up with this data, and particularly about this population health-related quality of life data, but what we're going to do with it. So I kind of think we should be this moral imperative of something that if you can get data from people that you're going to use it for, actually use it. And it's not just an academic exercise, that's just something I put it on there. And also, currently doing the study for EQ-5D 5L, and that's a really fortunate. And so we've got 24 people, 16 to 19. And they're doing the same for the EQ-5D one. And the gym, who are excited about the and we're talking out it's just such a great thing to be part of, to listen to these young people talk about how they make decisions and trade off different health states, and including those that are considered worse than dead. And I wanted to see that particularly the 16 and 17-year-olds can do those sorts of things. And the ones on the school absolutely can. And I'm really interested in, we ask at the end, do you think what you've done today, something should be used in national policy, and absolutely. They do say that maybe adults could be used as well in case we can't balance, but it's a really interesting study. Just finished the last interview before I came here. And I use it as an economic evaluation. So it's quite a bit about me to start with, but this is just a background of all the different ways that you can use the EQ-5D, and I'm happy to discuss it with you. Oh, the background to the African cohort study, which is what this session is about. And we sent the African Congress that was held there was a call by Anita Hetzman, who's a group, to see if there was an interest in population and it was, they wanted to shown. And so we had a long meeting, a virtual meeting, and you can see that 8 African countries were represented, and it's a surprise to see my first time there. Cairo is not actually a country, it's Egypt. So yes, I did pick that up this morning. So 8 countries. So Egypt, Ethiopia, Malawi, Morocco, Nigeria, South Africa, Tunisia, and Zimbabwe. And so those are the countries represented in the actual working group, but it doesn't mean that the study is limited to those countries. Okay. Can you move the slide on if that's not going to work for me?
Did I touch something before? Do I have to actually wave my hand? Is it going now? I feel like banging it, but maybe. Oh, there you go. Did it go again? Great. So, here's a list of the co-investigators who are involved in the actual study and who met when we met virtually. And is anyone here who's one of the co-investigators? Because I'd be really embarrassed to think that I'm talking on your behalf and I didn't know it. So I was invited to present on behalf of the group, but I'd like to say that I am presenting on behalf of the group and I'd like to thank Begashore for giving me all the information to present, but it is the co-investigators' work. So I'm in an advisory group to do with this, along with Sarah and Juanita and Ali Stolt from the Uruguay Foundation, but it is the co-investigators here who are leading and driving the project. I'm just giving a summary of where they're at. So at the initial meeting, you can imagine that it was quite a broad discussion to start with. And really, it's because, as you all know, Africa is a diverse continent. And because of that, there are lots of complexities in terms of the variations in healthcare systems, cultural beliefs, and socioeconomic conditions. And so it's really hard to think about how can we use all that diversity and bring it together and do something with that. But we want to be able to understand health-related quality of life if we want to make a difference. And so we shouldn't let that dissuade us from trying to do something about it. And we need to understand health-related quality of life if we want to address any issues, particularly disparities and inequality in health-related quality of life. So although there's complexities with different, within these 8 different countries, but with everything else as well, we decided to still think about this as the kind of the broader, bigger picture, and then came up with aims specifically around that there. So we wanted to assess the health-related quality of life of populations and countries from the African continent. So these are really big aims. To investigate the characteristics associated with lower health-related quality of life, because if we can get an understanding of which groups have got lower health-related quality of life, it might help drive policy so that we can actually start looking at those disparities. And so that's really aim 3, explore health inequalities within and across the 8, the African countries. But we acknowledge these are lofty ambitions and aims. And so we thought what we should do is start a bit smaller and actually take a stock take first of what is currently happening. So before we go too far ahead of ourselves, are there any, what countries are using health-related quality of life instruments? What instruments are they? What are they measuring? Does it differ between regions, population groups, countries? So we thought we'd do a scoping review to start with that. So the co-investigators put together a proposal, wrote it up, did it all online, obviously, and had a bit of guidance from the advisory group, submitted it to the Uruguay, the 14th joint call for proposals for funding, and it got funded, which is great. So then the work begins. So the aims of the scoping review are to synthesise the available evidence that's already there in terms of health-related quality of life measures, understand the rationale for using them. And, so again, I guess it's getting back to that point too. Why is it collected and what is done with that data? What are the data and what is done with it? And is it used in clinical practice, clinical trials, industry? Like, what's it used for? And then we want to be able to describe the key characteristics. And by doing that, like to be able to go the recruitment, populations, methods of data collection and other variables, that will give us an idea of if we want to branch out, when we want to get to the next step and branch out further, what we can learn from there. Did I just skip one? No. So the methods are, and I don't know how many people have done scoping reviews or not, but they're not small. It is quite a bit of work involved in them. So it's guided by the PRISMA scoping review and Joanna Briggs Institute Reviewer's Manual. And you can see that on the right-hand side, there's a checklist there. Don't worry about trying to see it, but basically there's about 20 different steps and an additional 2 to tick off as you're going. And what's really good about following some sort of process like this is it makes it really transparent and you know which step to follow and what to do next, and you're justifying it all the way through. It also makes it much easier when it comes to writing up your results because you've kind of followed everything as you've gone. So just following those guidelines, this is some of the headings that I'll just briefly go over. So the rationale, which I've sort of already explained, is that we want to identify gaps in knowledge and highlight strengths and limitations of existing measures. And like anything, knowing limitations and barriers can be just as good as knowing what works well, because you think, well, we won't do that then. So learning from everything else with the limitations and barriers. Ideally, to make recommendations from it, to see what we've got to make recommendations that might help improve health-related quality of life of people. And most importantly, to set this baseline assessment. So it's kind of like we've got a stock take of what's currently being used, so then that we can look at that large-scale population study, whether it's all countries, some countries, whatever that's going to look like. And I mentioned too here that when we're saying about these measures, it's not necessarily just the EQ-5D. So yes, the EQ-5D is part of it, and originally we kind of thought, is it just that? But it's not, because we don't know what measures are being used. We don't know if it is the most commonly used instrument internationally, but it might not be in African countries. It might be many other sort of instruments, whether generic or disease specific. So we need to kind of gauge all of them to see what this looks like in terms of the EQ-5D. So as Paula said, we can say the merits and the benefits of using the EQ-5D, but it is just one health-related quality of life measure. And often, if you've used them before, you often use a generic, which this is, with a disease-specific instrument as well. So these are just sort of the questions. So after the rationale, the next step is what are the questions that come from it? And, what have been reported, what were the aims and purposes of the study, what measures, who are the users, what are the sample characteristics and methods of data collection. And as I mentioned before, identifying any barriers is always useful for planning future studies. Next is eligibility criteria in terms of inclusion and exclusion criteria. So any studies that were included are empirical studies, so randomised and non-randomised controlled trials, observational, for example, cohort and descriptive designs, conducted in African countries, general population, any gender, age, ethnicity and socioeconomic status. So it's not restricted to any particular age group, meaning we could end up with just child-specific tools right through to adult-specific tools as well. And the health-related quality of life has got to be used as an outcome measure. So I managed to identify Egypt as a country in this one. And so these are the African countries that will be included in the scoping review. So the exclusion criteria, which generally is just what's not included, or the opposite of it, is not included if it's outside of Africa, if it doesn't mention health-related quality of life as an outcome measure, if there are duplicates, and if full text can't be located. So if you've ever done these before, sometimes it looks like there are really promising studies that you can include, but you can't find the full text. So it means that they can't be included. The next step is looking at the search strategy, and you can see this comes, 4 minutes. I start speaking really quickly and then no one will understand me. You can see here that we've got health-related quality of life and the different countries here. Concept context framework. And we started off with just a preliminary search, so that what we could do is then from that see, are there any words that we're missing, any keywords that we need to do? So it's kind of like a practice round. And if we get that right, then we can put it out for the other databases. And the date was from whenever they started to the end date was April 2023. So this was the pilot study, which used the Medline and gives you an idea of some of the words there, where we looked at abstract keywords, subject headings, specific to each database. And I think we got something like 3,990 citations just from doing that pilot one. And then the results of that, we did it wider so we could put it over other databases. The next part is the data extraction and screening. And so it was agreed that 3 to 4 members of the group would be responsible for independently reviewing the papers that were found in terms of title and full text. And then after that was done, 3 to 4, and it might be the same, or some of them might be the same members of the group, would then do the full text one. And then the advisory group would step in if there were any conflicts where people couldn't be agreed whether to put them in or not. And the Prisma flowchart was used to document everything as we go. So once again, the summary of it, so we're sorting and charting the data, 2 things, kind of that numerical part of the numbers relating to everything, and mapping it or charting it. So hopefully we can see, what is the strength of evidence we've got, and hopefully that geographical spread. And then also being able to look at within it, the study design. Is it an RCT? Is it qualitative study? What's the population, the sample size, age, approaches and modes of data collection. So I know that you're saying that not many people use paper now. A lot of people actually do still use paper, and particularly, it can be different age groups as well. They go, can you not mail it out? Which might be a foreign concept for lots of people, but it could be, paper-based or online-based or telephone. It could be by proxy, where you've got a parent or a caregiver or a clinician answering on behalf of someone. So those sorts of things. What's the setting? Is it a hospital, a clinic, a general practice? Is it health technology assessment or policy? What level is it? What's that setting that we're looking at? And what sort of other variables, like are they going to do like education and income and chronic disease status? I've got 1 minute, so I'm going to have to really hurry up. So then we will collate, summarize and report. And basically a lot to do with in terms of what the conditions are and the health conditions, but it's also going to depend what other data and variables were collected with the health-related quality of life measures. And the advisory group will help in terms of synthesizing all that. So the progress to date, I'm going to zoom through the next 2 slides, but you can see that we looked at a whole lot of other databases, including grey literature, because we wanted to look at dissertations and theses and reports and all those sorts of things, because it's not always published. And so we might be losing stuff if we don't look at all that other area as well. And so here are the results, and you can see that we've got over 20,000 citations. And after the duplications are taken out, 16,000 to screen. So no small job. So we're currently now in that first phase where we're looking at the titles and the abstracts for screening. And then I love when you can really simply just put July, August, September, we'll get all this done. So at least you won't be able to hold me to that, but it looks really tidy, doesn't it? And so let's hope that we can do that. But you just have to hear 16,000 and you think, oh, there's a bit of work involved. So I'll finish now on key messages. And one is like key stakeholders. If you're going to do any project, who should be involved? And I think you need to think about what your aims and objectives are first to know who should be involved in that. Start small. And so, yes, we've got those aims for the PopQual Africa, but we can't get there without doing the smaller steps first and having those concrete measures. And if anyone's an academic and had to apply for funding, you will know that the success of getting funding often relies on what you've had before. So sometimes showing that you've done a smaller study and you've built up and you can do those gaps, or it could be that you try to aim high and it doesn't work. So nothing's lost, and it's a very good step to help progress further ones. And no one size fits all. So learn from others. So in this case here, where there's an advisory team, we helped to start up, we helped sort of to try to secure that funding, but then we kind of step back from that. So learning from others so you don't make the same mistakes, or someone can tell you what to do. This really worked. It's so helpful and useful. So feel free to reach out to, see a paper and think that looks interesting, contact the author. It's a really good start. It's really helpful that way. So, sorry, Paula, for going a wee bit over. Okay. Right. Okay. Thanks.
On the right.
I think on no questions for that, the last photo was from the right side months ago. So I can
So I'm assuming there are no questions for Jody for now, so I can move on.
We can take some questions after the coffee.
Right.
We're looking at everyone, I feel like we need to get to coffee.
All right, so we still continue, right? All right, okay, how much time do you have?
You have 20 minutes.
20 minutes, all right. Good, thank you so much. Thank you all for being here for this session. Thank you, Paula, for inviting me to be here. My name is Kopal Sinha. I just said before, I'm at Macquarie University in Sydney. And what I'm going to be talking about today is using the EQ-5D in India. And before I start off with this long title that I have here, take your time to digest, I'll tell you the story behind the whole thing. So my association with working with HR quals is going back to 2006 and 7. Immediately finishing after my PhD, I landed this job at the Center for Health Economics at Monash University, where they're looking for somebody to analyze the AQOL, which is the Australian Quality of Life instrument that they're building, and they want an econometrician on board to do some econometric analysis. And I go and I look at the data, and my PhD was nutrition and health outcomes in India. And I'm saying to these people, you have collected all this health data, but you don't have any data on their socioeconomic background. And does that worry you? And the project lead, Jeff Richardson, says, no, this is the way it is. And I'm thinking, no, apart from gender and apart from the age of the person, you need more information to be able to analyze how health kind of is being built. And people nodding their heads would be able to understand me coming from a low socioeconomic background country. I could kind of see the relation there, but it was too early, I think, back then. And since then, it was at the back of my mind that there needs to be a study where you analyze the socioeconomic situation of a person and the health outcomes. So that's the kind of the background. And I don't know how many years forward, nobody's allowed to tell me that. I do a study using secondary data for various countries, Australia, India, where I built measure of multidimensional deprivation, where we say that bottom line income is not the only measure for your overall well-being. You need to have more information, and that's where the multidimensional deprivation studies that I've done came around. And I really wanted to do that for health because I was doing that for AQOL, and there was this thing that was in the back of my head. And long story short, the EQ-5D, the Eurocall group, has put out call for a proposal saying that we want to study the effect of COVID on health outcomes. And that is where kind of this whole study is coming from, and the funding was drawn from and all. So I'd like to first acknowledge the lands where this study was, slides were made, which is Macquarie University campus in Sydney. And that's where the bulk of the work is happening for this project. So as I said, I've been working on this thing for a very long time. Income is a poor measure of individuals' well-being. Everybody would be knowing about this now. And disadvantage is a multidimensional concept. And people who work on multidimensional disadvantage have seen Al-Khari and Foster's study in 2011 doing that. Based on that study and some other study, the Human Development Report says that, look, we are going to go multidimensional when we do poverty analysis, but they focus on 3 domains or dimensions, which is health, income, and your education, right? And people who would have a flair for this, but understand that no, that is also not the best way to go. But yes, you have to draw a line somewhere. And that's where they did. So what they found, the difference low in the countries with very high level of development and diverge significantly for lower levels of development as well. So what they haven't done and what subsequent researchers wanted to do now is look at the time aspect of things, right? So if I don't have much income today, but I have enough income tomorrow, does that affect my well-being in the following year or the following time period, right? So time aspect is important. And that's where chronic poverty and transient poverty, coming in and out of poverty, is important. The only issue is that data for these kind of poverties across time is first hard to collect when you look at the low and middle income countries, and second is rare to find. So most of the studies that you find are going to be cross-section studies. Even the DHS, which most of us know about, is cross-section across time for all these countries. So so that's a little bit of background. My work on this, I've done some work in 2019 and then another work in 2011. And in the 2019 work, we used data for China to see how multidimensional deprivation can be designed in a way where you have a time aspect. Time aspect has 2 things. One is how many domains, and you know what I mean when I say domains, are you deprived in, and how long in each domain are you deprived in? That will make a huge difference, right? And that's the measure that we built in that first paper, I'll say over there. In the second study that I put out there, we tried to see how this multidimensional measure that we've got across time would be valid in a wealthy country. So you take the data for the UK, we use biomarker data that the UKHLS has, and we say, look, let's go around taking the 20 years of UKHLS data, build that measure of multidimensional deprivation and see how does it affect your health outcomes. There was a huge gradient, and the health outcomes I'm talking here is biomarkers, which is very erratic, not consistent, and we could see a gradient there as well. So that's kind of more of a convinced argument that, look, you need to have a time domain aspect when we measure multidimensional deprivation. So what is the study then? The study then that we have here with the Eurocall group is in the context of COVID-19, right? So it's funded just around COVID was landed 2021. So how does COVID and its symptoms affect multidimensional disadvantage and the health-related quality of life is what the bottom line of this is. So going back to what I was saying before, we are trying to see how has COVID-19 impacted the socioeconomic disadvantage in India, which is a large country. Is there a difference in the health-related quality of life of individuals that are affected by COVID or not? And are the various population subgroups faring differently in the post-COVID world? And we're also looking at the long COVID kind of story, how many symptoms you have and how they're vulnerable to having socioeconomic disadvantage if you've got long COVID. And what dimensions should the policymakers target if they're wanting to make a change or if they're wanting to support people who have been suffering with this disease? That's my team over there. Me at the top, Yonyan Gu, who's also here, was supposed to be at this session, but has gone sightseeing. So that's fine. I have Nils Gutakar from University of York, and we have Juanita from Erasmus, and the whole thing is funded by by the Eurocall group. And thank you so much for that support, Eurocall. So what is the aim of this project? So when I say India, right, how many people worry about EQ-5D being measured, so to speak, in India for ones who are using EQ-5D? A question. Sorry, I'm in that off teaching mode, just finished my teaching. So I'm kind of going out asking questions, and being perfect students, you are allowed to be quiet. So anyhow, so yes, so the biggest challenge that we had was that you're trying to measure EQ-5D in India, right? How well is that going to pan out, right? And for obvious reasons that have been said before. What is the average impact of experiencing long COVID? So COVID is the first thing that we kind of try to see. Sampling is not based on COVID, it's a population study. So we're kind of just going by the population sampling styles without focusing on, and then we try to see long COVID situations and what domains and levels affect this kind of thing. And what is the mechanism of association between the multidimensional disadvantage and the persistence and duration? So when I say persistence, I'm talking about continuing deprivation across time. And when I say duration, I'm talking about how many domains is this person disadvantaged in one particular period. So what are the features of this INDIPOL project? So we called it INDIPOL. It's the first population represented with longitudinal data for long COVID and health-related quality life in India. So if you Google India and EQ-5D, there's several studies being done. Most of them are clinical studies, the way clinicians have been doing it. There has been no population-based study of this style before. How do we do? Oh, that's an ample time. So collect data for 4 waves and run a pre-COVID pandemic recall, right? So when I say dynamic multidimensional deprivation, it's obvious I need time. I need data points across time. So what we're doing here is that we're having 4 waves. Why do we do 4 waves? Is that the measure that we develop needs at least 4 to 5 days. Otherwise, theoretically, it falls apart. So that's the reason for 4 waves. One pre-COVID pandemic recall, right? So there are reservations about recalls, and you have lots of studies on that, but we are still going with it and trying to ask people, what was your health well-being situation before COVID, right? And when I say before COVID, for people who are from India or know anything about India, there's this big festival we have, Diwali, which falls end of the year. And we are going to refer to that point in time before COVID, which is 2019, and say that, all right, in Diwali 2019, what was your well-being and assets and so on and so forth. Now, since most COVID symptoms last 3 months, we are going to take 3 to 4 months of a recall, right? And the idea is that if somebody has had COVID over the course of our study, we are able to pick up their long COVID symptoms, because, I mean, there could be a discussion about how long COVID lasts and so on, but that's what we kind of propose there. So what is the scope for this kind of a research? I think there's huge scope, of course. COVID-19 vaccination, long COVID information we're collecting for these people. We have EQ-5D fiber across Indian states, which is not done before. And we have socioeconomic disadvantage, right? Apart from what we are proposing to do here, there's huge potential for this data to be used by people who are going to be, we're going to be sharing this data after the study is completed. So how we do with the sampling design? What is the idea of doing the sampling when we say it's a population-based study? So quickly on that, we follow the literature. In whatever I've said here, there is literature around that. So if you're questioning something, please talk to me later. I'll explain more. We have a 70% of a response rate across waves, assuming that we say we have a sample size of 3,000 households, right? So here we're saying households. Most population-based studies go to the individual level. Why we have a household here as our primary sampling unit? Any suggestions, any thoughts? You're allowed to stay quiet. So the way COVID operates is that if I get it, my partner, my children are kind of bound to be exposed to the disease. So it makes sense for household to be a primary sampling unit for us, right? And why we are doing that? Because within a household, even if I get COVID, my husband doesn't get COVID, he might be exposed to some long COVID, which gets undetected. So we thought it was very good. I had a tough time debating this with the reviewers of the Europol group, but yes, I could convince them at the end. So yes, that's the reason for having 3,000 households. So we did the power analysis and all of that. All those numbers are there, and effect size for COVID, non-COVID, poor socioeconomic background, high socioeconomic background, all of that was accounted for in doing that kind of thing. How would we do the validation for this size? So we looked at the effect size for EQ-5D being reported in all those similar countries, and then said, look, this is what the sample size should look like. So actually, the power analysis said 2,000 something sample, but we are kind of going 3,000 because there's going to be attrition along the way that we need to be accounting for. So we'll have all household members 18 years and above to be surveyed, which on an average in an Indian household, we have 4 members. So if you do the math, it's 12,000 approximately individuals that we're looking at. And to maximize participation across waves, you're going to have some kind of a voucher given out to the people at the end of the 4th wave. This is the greens are the states that we're trying to sample and survey. And while we started off with that, there was another state, which is the northeast side over there, Meghalaya. But because of certain things, language issues and translation issues for the EQ-5D, etc., we kind of changed that to Maharashtra there. So somebody might ask, how did you choose those states across that big, large country? So we try to use the states based on the demographic characteristics that we have at the top of there, and overall countries at the bottom. So a good range across the profile for the entire country. So for each state, once these states have been selected, we follow a 2-stage sampling strategy. We select the primary sampling unit from the rural-urban region of each state. For the first stage, we kind of do a substrata-based number of households and number of SC/ST. When I say SC/ST, is the socioeconomic deprived poor sections of the society. And then we do an implicit stratification within each stratum, where the PSU will be sorted based on the female literacy to start off with. So overall, after we do all that sampling design, we have 30 PSU in each state from the rural and the urban sector. And then for each household within each PSU, we do a mapping and listing for each section of that primary sampling unit. And we have divided the large PSUs into smaller ones and then randomly select one wing and then do the mapping and listing. Once all the households are mapped and listed, we randomly select the number of households that we need in that PSU and do the survey for them. What are the types of questions we're asking? So we have 2 broad sections to the survey. One is the household questionnaire, and then you have the individual questionnaire. Household questionnaire will be asked of the head of the household or the main respondent of the household that we get when we go to the household. And we'll try to get all that information on the vaccination history of all members of the household, their assets, their income, and the gender, and whatever you have for the household members. And for the individual, then we do the EQ-5D, the PHQ-9, the long COVID status history, and then some alcohol related and individual assets and income of that individual as well. So how do we do the value sets for India? So lucky or unlucky, I don't know. There was this study in 2022 that came out, which has done valuation for these states of India. So we'll be using those numbers there. The only difference between our study, which is on the right, and their study is that they have just one less state than what we have here. We've got Maharashtra over there, and they don't. So we might as well use one of the neighboring states. That shouldn't affect the analysis much. So we have done the survey pilot. Last week it was finished, and we have done it in one region of Uttar Pradesh. We've completed the mapping listing of the district, both rural and urban. We have 59 households. Each household get consent for the interview. Now, when I say each household gave consent, I came back. It's not the each household. Of the mapping and listing, first they were asked whether you're happy to part of the survey. The ones who said yes would then kind of approached for the mains pilot survey. We have individual data for around 275 individuals now that sits to be analyzed. That's a picture from the urban side. I was so excited when I saw that picture because it gives you that it's come to life kind of a thing, right? So the household size is one of the big issues that we have to kind of think about, because as you can see, on an average, we anticipated 4 members in a household. It's coming out of 5. It's kind of more than 5 in the urban areas there. So that's something that we need to think about. The informants of the households was around 40 years of age in general. Females were more somewhat than males, which makes sense. Males might be out to work or something. And these are some of the main kind of overall survey feedback that was sent back to us saying that what was the quality of the response. As you can see, 49% was a good response. I put everything there the way it was without, I could have kind of combined a few there. But yes, the idea is that it was a pretty healthy pilot that went on. So then the final thing that comes to kind of worry about or think about at this stage is that retention of these people. Some of the feedback that I got was people were away at the time that they went for the survey. So if they are available for an interview in the first wave, they might not be in the future waves. How are we going to manage that? Right. Urban response are difficult to retain because it's a busier life in the urban areas. So there might be something that we need to think about separately. We might analyze the rural urban separately. Language translations, big issue for EQ-5D because they don't have translations for all the states that I want to survey. And even where they have translations, it's how should I say, we're using this recall right. So we need to get a modification for the EQ-5D, which is a long discussion with the legal team at EQ. But yes, that is kind of an issue we need to sort out. Finalizing stage now, so not that bad. Translation and population norms for other instruments. So we have used EQ-5D. We have the population norms from this recent study, but the other instruments I'm using, whether there is a population norm for those, how am I going to manage that? So maybe we'll use some other similar country numbers from there. Cultural differences and perceptions about the HR core. So that is something which goes back to my story, starting off with the AQUAL. Cultural differences are huge. Some of the questions, not essentially EQ-5D, people had difficulty understanding. So when you say your well-being, they don't understand well-being the way that you do in the Western world. So what we would call here as poor health and poor health outcome might still be a good health outcome there, right? So it's a culturally closed-knit society. Somebody might not have mobility issues because they have somebody always helping out within the family for them to move around in the house. So it's a huge cultural thing. So one of the people said that, oh, what do you mean I can't move around? I have family members to help me around. What do you mean I can't change, whatever. So that was something that I think would be interesting to look at carefully. And the completeness of survey at the end of the day. So whether people are saying completing the survey or they're kind of leaving midway or not able to follow. So these are some of the challenges that we have. If you have any questions, please get in touch. Please connect, and happy to hear any questions that you might have later on. But yes, for now, that's it from me. Thank you so much for listening.
Good afternoon. I'm Dave Scott, and I'm going to share with you a very exciting EuroQual project called the EQ-DAPHNE, which stands for the EuroQual Data for Assessment of Population Health Needs and Instrument Evaluation. To tell you a bit about myself, I am South African, as Paula was saying earlier, living in Cape Town. And I've worked for many years at the University of Cape Town in the Department of Health and Rehabilitation Sciences in the Physiotherapy Division. And this is where I was first introduced to the EuroQual measure, doing health-related quality of life research, mainly on children, using their youth outcome measure. I've been a member of the EuroQual Foundation since 2018, and I'm currently the South African representative on the EQ-DAPHNE team. And I'm also a member of the Version Management Committee, which oversees the translations of the different outcome measures. To get back to the EQ-DAPHNE project, the overall aim is to create a research infrastructure for the EuroQual group that would support a variety of research projects. And this will be achieved through two broad domains. Firstly, to assess population health status using Euroqual instruments to develop population-specific health norms, assess the disease burden in a particular population, and population health inequities. But it could also be used to create sub-studies such as social determinants of health, personal health behaviors, attitudes, healthcare systems, expectations, and experience. The second large research domain includes comparative performance or validation of the Euroqual instruments. And in this particular study, we'll be looking at the EQ-5D 5L and the newly developed EQ-HWB. To briefly give you an overview of these two instruments, the Euroqual 5-dimension 5-level is a self-report survey that measures quality of life across 5 domains: mobility, self-care, usual activities, pain or discomfort, and anxiety or depression. Each dimension is scored on a 5-level severity ranking that ranges from no problems through to extreme problems, and is widely used in cost-effectiveness analysis. The Euroqual Health and Wellbeing Instrument is the newly developed standardized measure of aspects of health and well-being with 25 items, assessing a range of effects, including but not limited to the impact of health and well-being of care recipients as well as caregivers. And this will be accompanied by preference-weighted value sets to facilitate its use in the economic evaluation of health and social care. The EQ-Daphne team is led by 2 experienced Euroqual researchers, Jeff Johnson from the University of Alberta in Canada, and Bas Janssen, who's based at the Euroqual Research Foundation in the Netherlands. Together with these 2 members, together with these 2 plus 2 other members, they will form the project executive. Then there are 11 co-investigators with an interest in or experience in population health and or comparative instrument evaluation. The 11 investigators are uniquely placed in countries being included in the study, and their primary roles are to assist with project planning, coordinating the local or country, regional data collection. And this is also where any sub-study objectives can also be included. The team is further divided into 2 groups, being the population norms and the instrument comparison subgroups. The EQ-Daphne project aims to use a cross-sectional survey design to collect web-based data using the services of a data collection agency from 15 different countries around the world, with approximately 4,000 people per country. We intend to administer a core survey with the potential for additional country survey modules to be deployed as needed. The EQ-Daphne is planned to run over 3 years initially, starting this year, with the possibility of extending it for another 3 years. In setting up the survey for assessment of data quality, we had the Maths in Health team assist with programming in Lime Survey. Some of the considerations that were taken into account when we were selecting countries was firstly based on the availability of the EQ measure in that country, in the language for that country. So we started with English-speaking countries such as the UK, Australia, New Zealand, English-speaking Canada, and the US. As other countries will need the survey to be translated into other languages, time will be needed for these translations. So in round 2, the countries to be included are likely to be French Canadian, Chile, China, Netherlands, Poland, and Singapore. And in round 3, we plan to include the Southern African countries, such as South Africa, Zimbabwe, Malawi, and Namibia, where more translations will be required. Feasibility of survey sampling also needs to be taken into account. For example, an online survey may result in representativeness in some countries, but other countries will definitely need live or in-person sampling, such as South Africa. It is anticipated that some countries will require local ethical approval and not just the overall approval which has been granted by the Research Ethics Board at the University of Alberta. So the core survey consists of 6 sections. 1, general health and quality of life. 2, self-care behaviors. 3 is a COVID-19 section. This is being reconsidered for possible exclusion, or rather focusing on symptoms of long COVID. Health use and insurance. Demographics and social determinants of health. And lastly, there's a section for evaluating the survey. As mentioned, the Euroqual instruments used in the general health and quality of life section are the EQ-5D 5L and the newly developed EQ-HWB long form, or 3 sets of previously designed and used response heterogeneity vignettes. So using these 2 outcome measures, we will perform preliminary checks for population norms and main equity stratifiers, and conduct preliminary checks for measurements properties for instrument comparison. The EQ-DAPHNE survey platform is planned for an online platform initially, with the need to consider other different platforms for different countries, but allowing for a modular format to enable customization for country-specific research objectives. So the UK pilot study was conducted from the 6th to the 20th of April this year to evaluate some facets of the survey, such as the survey design and elements of the survey, data quality, effectiveness of specific questions, and response options. The NATA sent out a total of 4,538 surveys using the UK census representation for age and sex groups, and this was done across England, Northern Ireland, Scotland, and Wales. However, we do know that merely taking age, gender, and even education into account will not suffice. We also need to aim for representativeness between rural and urban areas in a country, between having no health condition versus having a health condition or caring for somebody with a health condition, and between different socioeconomic groups. Of the 4,538 surveys sent out, 4,382 individuals responded, which was a response rate of 96.6%, which is very good. However, not all of these participants provided consent, so their data was excluded. Of the 3,406 respondents who did provide consent, a further 392 were excluded for either dropping out without answering any questions in the survey, or incorrect reporting of age, or they did not complete the full survey. So the remaining 3,012 respondents who did complete the survey were included in the analysis. This tells us that oversampling will be needed to achieve the 4,000 respondents per country that we aimed for. So what are the other lessons that we learned from the UK pilot study? It should be noted that as yet, no formal analysis has been done to determine the population norms using the EQ-5D 5L, but a 5-digit health profile was elicited for each participant, and the measurement properties for instrument comparison still needs to be analyzed. Randomizing versions with the response heterogeneity vignettes was deemed suitable in combating survey bias amongst respondents, so we'll keep this going forward. The level of education proved to be a repeated question with consistently high levels of agreements at 92.7% and a kappa of 0.9. However, the single-rated health question showed a lower level of agreement, and this suggests a lot of variability or inconsistency in responses when people are asked to rate their own health. And it may have been influenced by the other questions asked about health throughout the survey. So going forward, it would be more useful to use a demographic question such as age to assess consistency, as this is unlikely to be affected by the other questions. As each question was time-stamped, it's possible to calculate how long it took the participants to complete the survey, with an overall mean time of 18.4 minutes, which is acceptable when completing an online survey. The time taken to complete the individual sections enabled the identification of speeders and laggers, whose data may or may not be included. In order to distinguish human respondents from bots, Google reCAPTCHA based on AI ML algorithms was used in the programming, providing a score between 0 and 1, with bots scoring closer to 0 and humans scoring closer to 1. In the pilot study, there were potential bot records of 0.3%, which is satisfyingly low, but this might be different in other countries. To identify potentially missed data, the survey employed 2 distinct designs. In one design, questions throughout the survey were labeled as non-mandatory, while in the other survey, all questions were designated as mandatory, the provided response option of prefer not to answer. The average percentage of missing data was 0.4% across all surveys, which again is acceptably low. However, it was noted when giving people the option to prefer not to answer, they tended to use that option more than those that skipped the question. So going forward, it might improve the number of missing responses by not giving this option. While there are still many challenges facing the EQ-Daphne team going forwards, such as how will representativeness of samples be assessed, what stratifications should be used for key demographic measures, and what is the best strategy to equate socioeconomic stratifications across countries. And for the instrument comparison team, which measures will be used to compare the performance of the 5L and the HWB? For instance, should we use the AQUAL or the Promise 29? The challenges facing, it keeps disappearing. The challenges for conducting the study in South Africa would include factors such as our diverse population with regards to socioeconomic education and urban versus rural criteria. When considering sampling, we would need to consider our population size, distribution between 9 provinces, urban versus rural distribution, and the fact that we have 11 official spoken languages. As for obtaining a representative sample, there are a number of considerations. A web-based method may only reach a small percentage of the urban population. Even though a larger population of people in South Africa might have access to smartphones, they would not necessarily be able to pay the data costs, and we experience unstable electrical and internet coverage. Most of our elderly people would not be competent in or even familiar with completing online surveys. We also have the South African POPI Act, which governs how personal information is handled, and this affects accessing participants' personal data. And we would definitely need country-specific ethics approval. But despite these challenges going forward, we are very pleased to be included in this research project. Thank you.
Thank you. And I'd actually given myself 10 minutes of leeway because I knew we were all getting run over. So we are a little bit early, I think, for coffee, because I think coffee does start at 3. Has anybody got any questions for the speakers just now? Yeah, and sorry, we need someone to do roving mics, which that someone might be me, actually.
Hello, I'm Katie from UTS in Sydney. Just a question on the last presentation. That UK study has a huge response rate, that is excellent. Were they incentivized? Were they paid as part of the company that recruited them, or how did they get such a high response rate?
They just got the usual thing through Donata, how like you can get points, rewards or something like that. So just the usual.
So it's an online panel.
Yeah, it's an online panel.
Yeah.
Through Donata.
But even still, that's
So you're paid with points.
You're paid
not
with
with
points.
cash.
Okay. Do you envisage that might be the same in some countries that might not have such facilities in terms of Yeah. Yeah, just an interesting observation. Thanks.
I think, and as a comment that I've written down for us to discuss after the break, because I think many of us are well-trained health economists, but actually things like how to run a survey was never covered in my economics lectures.
It's psychologists.
But, one of the things too is including those sort of quality checks of, is it bots or are people rushing through it and that sort of thing too? Yeah.
Yeah, my name is James from the University of Sheffield, PhD student in health economics. My question goes to Trudy. How can one join your team? Because that's health outcome measurement in Africa is part of one of the things that we are interested in, contributing together with a team of other 10 colleagues at Sheffield, doing research in Africa. The other bit is about whether the protocol is registered for the systematic scoping review and how can one have access to it. Does your review also focus on modeling studies that may have used health-related quality of life outcome measures within the models? And then my last question goes to the EQ-5D group. In light of the challenges that you've mentioned for South Africa, I'm interested to know what you are doing to circumvent what you've already highlighted and how representative the results will be. Thank you.
Can I just request, we've got another question as well. Can you choose one of those questions to answer, and then we'll park the other two for after coffee. And then of course you're all going to come back for after coffee then, because you want to know the answer.
And that's handy because I've only remembered the first one, which was that one. I'll get your name. I'll put you in touch with the team. In terms of the protocol, it's all written. I don't think it's been published yet, but it shouldn't be far away, but I can check on that because I think I forgot to mention it when it was on the slide.
I like the way that Trudy just attempts to answer them all, even though I said answer one.
I'm sorry, but
We've got another question over here, and then I think we will go and hunt down some caffeine because
I'll just answer the quick one about the EQ-5D. So we have actually been in contact with a data collection agency called GeoStrata, and they are familiar with doing data collection in countries like South Africa, but it is definitely going to be person to person, people going out, even so far as getting permission from the local headsmen of the different tribes. So luckily they have that experience and that will be done.
okay, now no one's going to come back after coffee. But maybe your question is going to want us to come back.
Hi, can you hear me? Hi, my name is Ho-Jun Son. I'm from Seoul National University. My research is in TB and HIV. I do a bit of epidemiology, health economics. My question is sort of in the first one, right? It's a scoping review and you're doing it for African continent. And I presume there must be some kind of a similar study that the scoping review of use of EQ-5D and different types of health quality of life instruments being used in other settings. Have the researchers, have you guys have looked at it, or were there any other precedent research like in European continent or Asian
That's a very
continent?
good question. Might answer that when we come back. No, just kidding. I'm not entirely sure. It's a really good question. I'd have to have a look and see if they've, when they wrote the protocol, if they came up with other ones like that,
So,
because that would be the first thing to look at, yes.
right. I mean, the reason I'm asking is it's very context specific. And then, it depends on how much of the research has been focused in this area. In this Europe or United States may be more prevalent as to others, not so prevalent, right? And then the other thing is I've been kind of trying to use EQ-5D because of a lot of conveniences, right? Simpler, trying to integrate these into randomized control trials of TB interventions and whatnot. The challenge is that, how does it map out with other instruments, right? So I've always included like WHO, breath, or other things. So it will be interesting to kind of look at how these instruments are being used against others.
Exactly. And that's why all the other instruments were included as well for that reason, because we just don't know.
Great.
And it'll be interesting to see what was used and why.
Yeah, great.
Okay, so we're in this space finally, and everybody's managed to come in now. For some Q&A, which can be, I might get the three speakers to come up and join me in this kind of comedy skit that we're doing up here. And questions from you. Don't hold any punches. Don't say, well, you know, feel free to question whether it should be the EQ-5D. I mean, we're not going to, it may not be the instrument. Just in the chat, then we were talking about capabilities, and I've done some own work and on capability measurement, and you know, so the difference between functioning and capabilities. Is there a space in there for that? But I guess think more about population health surveys in that sort of space and understanding why. So feel free with your questions and your comments, and I'll get these three to come up, and then I'll get some steps on my watch by walking around with the microphones. And if I might have a first question, maybe because I know it, which is either to Trudy or to Des, which is telling us about what these vignettes are.
I think that's for you, isn't it?
Well, no. Okay, so I'll answer my own question. So I've done some work on this notion of anchoring vignettes, which is the notion that my good health, you know, if I say my health is good, it might not be the same as somebody else saying their health is good, because we all have different reference points, right? Particularly if you hang out with people who are very fit. Their bad health was still going to be better than my good health, right? And so particularly in these population health surveys, there's a neat way of including anchoring vignettes in these hypothetical scenarios to try and understand what someone's reference point is. And I think if you're doing it across cultures, that's also quite important as well. So there's been some stuff on anchoring vignettes that you might want to do and you can include. So just kind of expand your question a little bit as well. But then we've got a question here from this woman.
Yes.
And do, you know, make sure we learn who everybody is, say your name and where you're from, and then we can all stalk each other later as well.
Hello, my name is Debbie Bigbro, and I'm from the University of Gothenburg, Sweden. I would like to ask how you could formulate the question about perceptions in regards to different health status. This is my first question, and the other about the education levels, how you could translate this when you compare different countries. Thank you.
It's a EQ-5D question.
So those are actually some of the challenges that we do have. Exactly how are we going to equate educational level across different countries where the education is different? And we haven't quite got all our stratifying points in place with that yet. It's one of the things that we're actually working on currently. Your other question was about?
The other question was about the perceptions of different health status. Maybe you would write.
We were talking at the break, and it's the perceptions, I guess it's just the understanding of health states and when you read it, what it means to you. And you were saying before, safe for mobility, going, I'm fine because I've got someone to help me. And I was giving an example of a young girl when I was doing a Think Aloud session, and this isn't a great advertisement for the EQ-5D, but anyway, she looked pretty much 100% health state to me. And she was ticking it, each dimension, and it came to self-care. And she pretty much looked like she was, you know, up there, all right. And she went, oh, I couldn't work out what to get dressed today, what to wear. I've got moderate problems with self-care. And I thought, oh, no, you haven't. But, you know, there is a perception. So there's always going to be what that means. And in fact, in the study I've just been doing with the young people, there were a couple of them that said, it would be really good if you can describe what this means. and even describe words like moderate. Or so it's kind of tricky because what something means to one person, it doesn't to another. So I think there's always going to be, you know, vignettes might help sometimes, but there is going to be different perceptions over different things. And also it's down to what people consider themselves. So if it's like how active you are, for some people that might be walking to a letterbox and they think that's active, and someone else active, I was thinking of this in another health related quality of life measure I was using. For someone else, it might be whether you can run a marathon. And so the same word can mean different things to different people. So I'm not really sure how you get over that without it just being simple.
Yes, hello everyone, and hello to the presenters. My name is Kenneth Katumba. I'm a health economist based at the MRC unit, MRC and LSHTM unit in Uganda, and also a PhD student. Thanks to the presenters, the work looks really good, and I wanted to, mine is not, it's a mix of a question and a reflection. So the EQ-5D is a very good tool. There are a number of tools out there to be used for population health, but the EQ-5D has its particularities, why it's very good. And it's gaining traction, especially in low and middle income countries and resource limited settings. But as we know, it is population specific. And most of these settings don't have validated value sets to be used. So, and then it's good that I did not know, but I've noticed that we're moving into using well-being measures also for the EQ well-being. So my question reflection is, what's the general direction of the Eurocall? Is it going deeper? So there's now EQ-5D, and then there is also the using well-being measures, so deeper into measurements of outcomes, or do we also want to look at going wider? So looking at these other countries that don't have value sets and helping them to get value sets. It's just a general question. We want to go deeper, or first go wider, then go deeper, because the issue, we may risk going deeper and we're not covering some people, because I've spoken to some colleagues and they want to use the EQ-5D, but they're looking at, they want to use the value set that we developed for Uganda, but the settings are similar, but not similar. So how wide specific to the different populations do we want to go? Thank you.
So we're going to have the beauty of passing this to another participant to answer. So Janine is also a member.
Hi, Kenneth. Nice to see you again. I think I want to throw that reflection back at you and say that it's quite difficult for Europol to develop value sets in regions or countries where value sets are not being used. So there needs to be evidence, and there needs to be engagement with stakeholders and acceptance of what the values are that are being generated and how they would be used within that district. We can't just generate value sets if they're not going to be applied. So perhaps that's something for all of us to think about as well.
And I guess the value sets are used in HTA settings. And we actually haven't really spoken a lot about value sets here, but at least in the work that I do, there are whole other ways you can also analyze EQ-5D data. You don't need to have a value set. And there's a very good free book that you can download that tells you all about how you can analyze the profiles and the VAS. And I think in a population health space, you don't always have to use the value set. But obviously, if you want to generate quality adjusted life years, you do need to use the value set. So there is a tension. And somebody's probably going to correct me, I don't think the Eurocall will fully fund a valuation study anymore. It has to be part funded by the country as well. So we've also moved away just from funding valuation studies. But yes, I think we're more interested now in like diversity as well, understanding how our instrument is used in different countries. So there's been some really interesting work that's come out of China about whether those 5 things we ask, how do they fit with the Chinese population? And I don't know if there's anybody here from China and even wants to, comment on this, but I understand whether you've got an appetite is very important in China. And so I'd be really healthy there, right? But it's very important for them. And so the idea that maybe the instrument is better if it actually has an additional, so it becomes 6 dimensions, which is something like appetite. And I think understanding how the instrument fares in a more diverse population, of which is not the Western Europe that it was invented in, is kind of the way that the instruments, the group is going now. Yeah. Question here and one over there.
So I don't think one needs to sort of agonize too much about culture and or whether it's gender or whatever in the context of these EQ-5Ds, because although I was talking to someone who said they just want to analyze what the quality of life is in the country, but normally it's in the context of an intervention, and the intervention is going to change something. So let's say I'm that woman who thinks I'm not fashionable, so I think there's a problem. Then you don't need to necessarily worry about it. There's an intervention, like say, whether it's a fashion school or an education or something that's changing that. And the point is, she might say she's on a scale of 3 to 3 out of 5 when you think she should really be 5. But the point is, with that intervention, they may move up from 3 to 3.5 or 3.5 to 4. So it's the change that's important. So if people will, and that's the context of that question earlier about perception, even if, as long as you're talking about the same person, and that's why it's very useful to have panel data. If you have panel data, then you can look at how that's changed. And in that case, it may not matter whether it's Africa or India or US or whatever, or even Australia or New Zealand. It should be in the context of an intervention. And so being very specific, it's the changes in the qualities that's important, not necessarily whether you get it right at a particular point in time.
Yeah. I believe just continuing on what you were discussing before, right? So, so just to give you a bit of we had a discussion just now saying that, look, there needs to be an intervention for you to be able to say that, look, the EQ-5D changed this way, the quality of life. And the intervention, I'll take your example exactly, is that if it's an education facility and there's no disability access, then the person who has kind of wanting to do the education might be, and the intervention might be that you provide access. Is that what your example was, right? So in the sense that we are doing the survey, the two things that, keeping that aspect in mind, is that first we are going pre-COVID as our main, I shouldn't say main, but yes, one of the baselines, so to speak, that what is your perception about what was happening pre-COVID. Now, I appreciate there are issues around recall and how good a recall is and all of that. So we're kind of following the literature along those lines. The other thing is that the benefit of doing a panel data, right, will be very important here, right? So give you an example. If in the first wave, for example, they don't have access to sanitation, right? When I say access to sanitation, do you have a personal toilet in the house? And if they say yes, right, mobility perception or mobility outcomes might not be that severe compared to somebody who has to go out in the bushes for every few hours to kind of so that could be something that we see in the first wave, but in the next wave, for whatever reason, they have better access to sanitation. I'm just taking an example of sanitation, but we have a host of other domains there. So in that sense, while the intervention is not in the sense that we are providing them with new toilet facility, through the program or through the survey that we're doing, but we will be able to utilize this change in accessibility on various fronts, which would be education, which would be, sorry, employment, sanitation, what kind of quality of house you have, and what kind of physical family support you have, right? So if after COVID, members of the household have migrated out of the house or out of the community to find more work, whatever be the case, that could be something you can explore, how that has affected their well-being across time. So while it's not designed intervention the way one would have, in the sense that it's unique for all respondents, we would be able to utilize the panel aspect to explore those things, I think. I don't know if that answers the question, but that's what kind of the mindset we have in the study. Yeah. Thank you. The question is very important.
Hi, I'm Dosh I'm a health economist from the South African Medical Research Council. My question to Trudy is, so we know Africa, much of the research is on infectious diseases, HIV, TB being one of it. I'm just interested about your definition that you used for health-related quality of life, given that many of these infectious diseases could have used sort of symptom specific, depending on the era, because you mentioned your start date was from the time of the database itself, for instance, HIV, right? So we know quality of life determined by ART, life-saving treatment. So just interested to know how you applied that definition then, because, a lot of the clinical trials could have used disease-specific or clinical measures.
So yeah, they're included.
Okay.
So in the search terms, it's disease specific as well.
Okay.
And so it should capture those sorts of like any sort of study. So all those search terms, it's very wide, should pick those things up. And then it's when we look at it, what's it applied to? Is it a clinical area or is it generic? What was the purpose of it? Who used it? What's the pop? So all that should come from that. So it should be picked up.
And then I was just interested, so the purpose of doing that systematic review to feed to your bigger goal, and then what was the bigger goal then of this Africa?
So the start of it was, the aim was, if you can assess health-related quality of life at a population level.
Yeah.
Which is quite lofty. And to be able to do that, it's like how to do it and what to do it with, because the thing was, well, we'll just use the EQ-5D and get population norms. And it's like, well, wait a minute. Will we? Is it currently being used? Is it feasible? What else has been used? What's it being used for? So that's why this is sort of getting that baseline to see what other measures have been used, how were people recruited, what's their sampling, what sort of studies were they, and using all that information, then it could be looked at in a wider sense of, is it feasible to be doing these studies? Is it a few larger studies, one big one, concentration on one area first, and then go further. So it's really just getting all that evidence first.
Okay, thanks. And then to the India and South Africa group, I guess similar to South Africa, we're going to experience, a lot of migration in panel surveys just by the nature of our setting. How are you guys going to manage that? And also given that you are looking at long status COVID-19, so probably you're needing to really track these people over time.
All right. So I think that is a challenge. Yes, I'll acknowledge that. What we are going to do is, as I said, it's a household that we're looking at. So we intend to follow the household across the 4 waves, right? Whether there is a movement in individuals is something that we will try not to try to optimize, in the sense that we'll try to follow up, see if the person is available later in the evening and those kind of things. But if the person is completely migrated, not coming back kind of a thing, so that is going to be a loss that we kind of have to endure. And I think the sampling that we've done is a little bit more than what would be required based on the statistics. So that should cover up for the missing ones. But all my fingers and toes crossed, I should be able to get a reasonable sample at the end of the day. But yes, it is a issue for all population samples if it's a panel.
Thank you. My name is Eric Lamontagne. I'm an economic session at UNAIDS. I followed all your presentation with interest. I'm just, as I said, a simple economist. As such, I'm more on benefit cost analysis than cost effectiveness analysis. So again, as I'm more in value of a statistical life than into qualies and dailies. This is perhaps why some of my questions may look disconnected. I have two questions. The first one is about, I followed, and I have forgot to say, one of those few economists who are doing surveys, particularly in Africa, but not only, global surveys on key population for HIV and AIDS. This being said, we are trying to measure the health status of people in a really, really short way, because we believe that our survey should not be more than 10 minutes. And I looked at your questionnaire, 5 plus this analog scale I'm interested in, but then how does it behave with other existing tools, like on mental health? You have one question on depression and anxiety, where we have an instrument called the EQ-5D, which is validated. So why only one question instead of someone like me who's doing survey choosing a fourth validated item translated in zillion languages? That's one. How about this? You have one question on disability. We have also the WHO disability schedule WUDAS assessment, a 6-item one, which is validated, and so on. So I guess you already studied this. Maybe I should have read before, but I would like to know, how do you assess the validity of EQ-5D with these other instruments? Because as researchers, we are confronted. Why should I use EQ-5D when I have EQ-4? And maybe you ask yourself the same question. So that's my first one. The second one is for the three of you. I like your presentation a lot. I followed and I learned about the aim, the rationale, the members, and so on. I would have liked to see some of the results, particularly with India, where you got our attention, the others too, as well. Because you are speaking to an audience of economists and some health economists as well. And you talk about socioeconomic disadvantages. But you don't say, okay, what's the result? I would like now this EQ-5D exists for like 3 decades or so. I don't want to see protocol of studies. I want to see results. I want you need to feed our appetite. Where is the beef? In fact, this is the question. So I'm sorry.
We're on a diet here.
It's difficult, but
this is the lean version.
I said I had 2 questions only, and I stopped here. But well, thank you very much. Sorry for being a bit long.
If I could just answer both of those from my point of view. So there's a lot of research that's been published around the validity of the instrument, particularly within a disease area. So there's a lot that shows it's valid in cancer. There's been some work understanding, thinking from EQ and colleagues, because depression and anxiety, we know, are 2 different types of mental health conditions, but in 1987, for some reason, they put them together and put a slash between them. And there's been some controversy about whether actually they should be 2 separate questions. And so there is a lot of research in that kind of space. I'm working currently in long COVID, as I've said, and we're going to test the validity, particularly because there is no instrument in long COVID, right? Because it's new. We're going to test the sensitivity of the instrument against other ways of measuring some of the long COVID symptoms. So there is a wealth of analysis and validity that happens, not just by members of the group, but a lot of other people. So there's no shortage. Why you should use the EQ-5D every another measure, it's hard to say. It's much clearer and obvious when you're doing an HTA, when you've got to do an economic evaluation, because it gives you that weight to use in a quality adjusted life year. But it's not necessarily black or white when you're doing other kind of longitudinal surveys in that sense. But we're just keen that we think there can be value, and it's short in that sort of sense. So that's the kind of answer on the validity. And I'll put my hand up and take responsibility for the infancy, let's call it that, the leanness of the presentations, is because this work is very much a new kind of strand, I think, in the group. there's a lot that's been done on the validity of the instrument. The instrument is probably published every week somewhere in use in HTA. But using it in population and health systems is a new space, and which is why we chose these 3 presentations, which just don't have results yet. But I guess a comment that I had on all of this is how long it does also take, right? Because clinical trials, they're a machine, right? They're well funded. You've got a captured audience because they need to come back for their drug. You know, they get followed up and there's quite a strong protocol. But the notion of like doing a household survey, going into the field, getting ethics for that in the first place, that all does take time. So I guess in 2 years' time, when we're in Canada, you will see us presenting the results in that sense. But again, it's also many of the studies are kind of in that space because we've now realized, you know, maybe it's a bias that I think the HTA space is a bit boring, and actually it's the population and health systems where actually there's a considerable value to be had. Only 15% of what we spend in health is probably governed by an HTA because that's pharmaceuticals. So I think actually understanding the health of the population and the health of individuals as they go through a health system is probably more interesting. So that was my answer. Does anybody else want to come in?
Just 2 more sentences to that. I think my apologies for that starving that I'm leaving you with. But I think just to follow up on Paula's thing, if I give you an example, this project was submitted to Eurocall group in late 2020 and 2021, around that time. And it's taken all this time to get the ethics approved from various states, from various places, to get the right partner who can help us with the data collection in India. Mind you, collecting data on in the field, right, is there's a lot of trust and a lot of responsibility that you need to really. So I might have gone out to, I'm not exaggerating, 15 different people who are proficient in data collection to get to that one person or one team that I've kind of relied on. So it's been a lot of hard work. In terms of the infancy of the study, I really wanted to present some good pilot results, but the the results only came out late last week. So, and that's after all the pushing and all the efforts that we've put in. But I can assure you, you'll be very happy when we meet again in Canada. I'll have you fantastic results out there. Yeah.
I think Kenneth just wants to come in on this.
Yes, she said it perfectly, but I wanted to add, to try and respond to the question, why use the EQ-5D? So to the boring HTA, when you're doing HTA, the recommendation is that because the example you gave of the PHQ-9, or looking at key populations, the recommendation is that you have a condition or disease specific measure, and then you have a general measure. So if you use the PHQ, then you're going to be able to compare other studies that have used PHQ. But then you also want to compare more generally with other conditions. So that is the benefit of using the EQ-5D. So the recommendation is for HTA, you have a disease specific like PHQ-9, and then you have the general, which is the EQ-5D, which can then allow you, just beyond the value sets, to compare across disease conditions. And if you're interested, someone from our team, the MRC, we've done a study and we've used in mental health, and we've used about 4 measures. I don't have them off it, and we have a presentation on comparing the results from them. So maybe we can chat after and have the details. But yeah, that's a very good
Thank you.
advantage.
I feel my proverb has come true when the participants have become the teachers. And we have the next question here.
Hey, my name is Nancy Boulos. I'm an instructor in St. Jude Children's Hospital in Memphis, Tennessee. So my question is to compare, you showed in one of the slides the study by Gianni that will help translate the health profiles to index scores, right? But if this study didn't exist, what was your plan? And I want to also know a little bit about how this study, I'm curious to know like how to do this index score study.
Yeah.
Like, and how feasible it is, and you know, like that's one question. And then second question also to you about the sample, how to calculate the sample. So you calculated the 3,000 I wasn't sure how, but if I'm doing the same for rare disease, how would I be able to calculate the sample size, especially if inside the disease there's several complications and several health states, then how can we calculate that?
Yeah. You look like the reviewers from Eurocall. I don't know how they look like, but you exactly look like that to me. I know how they would kind of, anyhow. To take your first question first is, which was what? Say that again.
What were you going to do?
I'm a bit jet lagged. Sorry.
What were you going to do? The values paper wasn't published.
So when we put in the proposal, right, that time the study was still not published. Okay, I knew they had the protocol, they were doing the study, but it was not published. So there what I did was I took all the studies, and I have listed that in the presentation, Hong Kong, China, whatever was available in the Southeast Asian region. And I promised that I will use these value sets. So Indonesia was one big one because there is a EQ-5D for Indonesia. So similar demographic profile, right, country you would take if there were no value sets. That was that would have been a long job for us because you would need to validate it against a few of them to make sense, right? But now that we have for India, so it's a convenience thing. Now coming to a second point about 3,000, the sample size we have, I use a standard power calculation analysis that you have in statistics. The benefit that I had was that I'm doing a population study. I had a backup of the way sampling is done in general population surveys in India, which is freely available. But what you say about rare diseases is very interesting, right? And to be honest, I'm not sure how would you go about, because rare diseases are not something that you can do at the population level and all of that. There was a discussion about focusing on COVID per se for our project, but I think we went with the population aspect rather than the COVID specific aspect, because that would really make it a very narrow study. We wanted to keep it broad for future users of the data and all. But yes, let me know, coming back to that proverb, when you come across how to do sampling for rare diseases stuff. Thank you.
And if anyone can, like, in a few minutes, explain how the index score value sets are calculated. Like, I'm really curious to know, like, how that study by Gianni or like others, how do they do that, like, to map out?
I think Paul should do that.
Actually, Trudy should do it because Trudy has led this. Oh, okay. So there is a protocol. Actually, Trudy didn't use the protocol. There is a protocol on how you do the valuation study, and this is testing me. And you ask a sample of individuals to do choice tasks and time trade-offs. I'm looking at Janine as well. Nodding. To then understand their preferences between different health states. And then once you have a group of individuals' preferences, you can then impute the ones that are missing, the health states that are missing. And so that's why they differ for different countries, because different countries and potentially different individuals and cultures within a country will have different preferences for the different health states. Yeah, so that's the valuation, and that's how you get that number where 0 is dead, 1 is full health. And sometimes you can get states that are worse than dead because people have an aversion, strangely, to death. You can analyze the EQ-5D without the value set as well. And so that's what the Devlin book does. That's free to download from the Eurocall website. There's lots of different ways because you get 5 numbers, remember? And within that, there's one of 5 numbers in each of the 5 questions, and then there's the visual analog scale. And so there's lots of different ways you can analyze the data without having the value set.
One last little question. Is there a list of the countries that actually have the value sets?
Yes, yeah.
Is it on the
It's on the website. Mm-hmm. Yep. Oh, you need to use a microphone, sorry, Kate. I know you're looking around like I don't have one.
Yes, yeah. No, I was just going to add to that as well to say, yeah, there's the time trade-off, but there's also the one with DCE as well. You can do the DCE in the valuation.
You have to get permission. So there's a what does VT stand for? There's EQ. The EQ-VT is the valuation technique as a specific protocol that you're supposed to follow. But in Australia, including I was on that paper, we used a discrete choice experiment instead to get valuation. Yeah. And that's
Yeah.
also, they use a different type of discrete choice experiment in New Zealand. Yeah.
Yeah.
And then you get a study, which is kind of, do you get different preferences whether you use a time trade-off versus a DCE?
Yes.
So there's no shortage of Euroqual kind of research out there in that sort of space. Yeah. Other questions? Oh, sorry. There's a question over here.
I wanted to find out when you're doing these socioeconomic population studies, do you use the ones with the value sets, or can you use the value sets, or do you use the index? Can you use the index with the value set?
If I understand your question correctly, I think we will be using the value sets. But yes, Rick, even if, going back to the previous question, even if the valuation sets were not available to us, either we would go to the similar demographic profile country value sets, or we could just go without value sets for a start and try to compare it within the society, within that population, how they're faring. For example, you could compare it with the mean, so assuming that mean has something to say, we would kind of say that. But now that we have the valuation sets, we have the flexibility of trying both things.
Okay. So the value of the value sets is expanding now.
Oh yeah, oh yeah, oh yeah.
And of course, you can also look at the change in some of the individual items over time as well. And so that might tell you something. So maybe some people who have got, who are more educated have less variation in one of the questions. And that's more obvious when you then analyze the profile than when you just try and report the values, because obviously that's all mixed up in the way the value is estimated. Yeah. I think Tommy was next.
Kia ora, everyone. Tommy Wilkinson from the Ministry of Health New Zealand, but also with my other hat, the Health Economics Unit here and UCT. So just with that South African hat on, a piece, and linking to Kenneth's question about the value sets, a piece of work we did in South Africa was to look at the cost per quality studies that have been done and to look at where the valuation was coming from. Most of them didn't actually even report where it was, but those that did, it was 50-50 UK and US value sets. And then taking that information to Department of Health, where we're trying to assist with the HDA processes, their fairly logical question was, well, why should we pay for a value set study if we're just going to use DALYs? So and so it's more sort of a comment that's sort of trying to make the case for the country studies to be done, because these value sets, although even though you might say, well, it's just in the HDA space, once you get that national consistency of using that, really will encourage the use of it in all clinical trials and things like that. So you could argue, if someone's doing a clinical trial in South Africa, you strongly argue use the EQ-5D because it'll directly translate it into decision-making at the Department of Health. But if the Department of Health is just going to take those sets that you produce and then just use DALYs anyway, it's a sort of a tricky argument to make. So I guess it's somewhat a comment, but just to encourage the use of those value sets, because they're sort of strategically useful and it encourages a lot of things. And it's really hard to chicken and egg say, well, you need to demonstrate that you're going to use it first. It's often it needs to be there to push the governments to start to use it. Yeah. Over.
Do you want to comment on that? Pass the and then microphone here. Oh.
So with more countries going towards UHC in Africa, I was wondering if there is any kind of guidance that you give people who come to you, and I mean, beyond saying use countries with a similar demographic profile, is there any other kind of guidance that you give people when they're doing their HTAs? Because the value sets that are available are, I don't know, Sub-Saharan Africa, East Africa, and so if someone is asking and we're generally using the UK.
Yeah. I'm going to guess in the chair's statement, which is consolidated health economics evaluation. I don't know what the R stands for. Reporting. They probably say something about using a country-specific, your country-specific value set, or I guess finding a country that's similar to you. And that the Euroqual group would be supportive of that. I think the Euroqual group would be happy to have a value set for every country. But but equally so, the Eurocall group is not going to fund a value set for every country though either.
It just seems the demand is increasing with UHC, with the move towards UHC. So, yeah.
Question here, and then we'll go there, Lisa.
Thanks. Lisa Gold, Deakin Uni in Australia. It's about exactly about your point and about Tommy's point and the point earlier from Uganda that so like all population health data, the more we use it, the better it's going to get. And look, I know the world, Euroqual at the moment is an imperfect world. I mean, I don't, in South Asia, which is where most of my team's work is, we'd probably prefer it didn't have the word Europe in the title, but it does. So it's EQ-5D. Let's go with that. Then it doesn't have.
It is EQ-5D.
Then it doesn't have Europe in the title.
Did you miss about it?
No, I've seen the asterisks, people online. I've seen the asterisks. I think the more we use it, the better the data is going to get, just like with all population health data. I think there's exactly like you said, there's an increasing case for using more measures of generic health status in our population health data. I mean, the more people that sort of look at DHS data and say, well, it's missing generic health status. We really need generic health status in DHS data so that we can look at all these things. And we're not in the world of being able to have panel data. Like, you know, most of us are just struggling to get any population level health status measures. So I think let's start with that. It's imperfect that we don't have a value set for every country, but you know, let's get a good one for South Africa and start using that. And let's get a good one for India and start using that in Bangladesh and Sri Lanka and other countries. And then then go pitch. We can go pitch to Euroqual and say, hey, we don't actually like using the Indian data set in Bangladesh because they're not the same country. And do it that way. But I think the more we use the data, the more we're going to get support to be able to do more research, and the more researchers we have in all the local universities, the more we can do that. So it's great. You know, we're seeing all the Europe. We could probably do with a list of Euroqual members that don't live in Europe. That might help. So we can see who to, you know, tap up. Tommy, are you a member?
I'll just add one quick thing to what Lisa was saying there. For people who are using demographic and health surveys and other surveys for low and middle income countries, the one thing that we notice is that while there has been a focus on child nutrition and maternal health when it comes to health and well-being, there's not much focus on the overall well-being, mental health, physical health, your ability to do stuff in these countries. So the fact that this kind of work is being promoted and supported is a big leap, I would say, in how we understand health outcomes and how we understand health and well-being. And to say that, look, it's not about mortality, because once a person is dead, doesn't matter, you know, to the rest of the population, if you know what I mean. And neither for the child nutrition, because there's this whole cohort of the working population whose mental health and physical health is also important, you know, going forward. Understanding that is important. So I think these studies would be a good step in that direction. Yeah, thank you.
And just before we go over here, I should also say, obviously, in the UK, they've recently done and they're redoing the 5L valuation set because there were some issues with the first version of the 5L. But it's also questionable as to whether they shouldn't redo the 3L value set, because that was done in the late 1980s, early 1990s, should I say, or maybe it was the late 1990s, because actually preferences change with time, right? And society has changed, even if your preferences haven't changed. You know, there's a lot more that you can do just because technology, and so you would change your preferences. So there is something also about updating preferences. And we also know how we're also better, I think, at measuring preferences as well. So, you know, there's something there in that sort of space. Question over here.
Yeah, thank you. I asked several questions before, but my kind of question is sort of related to people with developmental disorders. Now we've been focusing, I really love the idea of EQ-5D, the convenience where then you can integrate to many different scenarios, right? I'm already integrating these into various behavioral interventions, RCTs, and so on, so that you can elicit quality of life measures against the cost, and so that you can do natural cost effectiveness analysis in that trial. But I come to, you know, rationale, the question of these instruments are very difficult to administer when people have dysfunctions in understanding what these value measures are, right? I've just searched a couple of EQ-5D related issues of multiple sclerosis in New Zealand or other developmental disorders. I think these people are being left out. And how can we better kind of understand their quality of life? They're already having a quality of life issues, obviously, but then how can we engage these populations in these type of simplified tools so that we can kind of continue to monitor their quality of life issues over time? I think it will be interesting to think about. I mean, this is sort of out of the topic of all of the discussions you're having, but I think when we're asking generic questions for ideas and potential collaborations and other things, I think we really have to think about those people with developmental disorders.
And I don't know, Des, do you want to talk about that? Because we do have proxy reporting as well. And so there's been a lot of research looking at proxies. So proxy completing. There's even some research ongoing at the moment for the youth version about, do you ask the youths, that doesn't sound right, do you ask the adolescents, the children, to do the valuation? Do you get their preferences, or do you get the parental preferences and use them underneath it? And of course, these are all kind of, you know, a lot of the time these are questions we've already asked ourselves and we perhaps haven't publicly put it out there, you know, but sometimes we do publicly put it out there that there are some concerns and we're working on them, or there are just some, we can't necessarily get the answer to everything immediately because there are constrained resources.
Just in terms of that with the youth, in the study that I'm just doing now with the 16 to 19-year-olds, when they finish, we say, who do you think would be the best person to answer this on your behalf if it wasn't you? You know, parent, caregiver, school teacher, clinician, or sibling. And a lot of them would say a friend or a sibling. And they think that they would have a better understanding of their health state than, say, a parent. And particularly because, you know, in the evidence, it shows that when you're looking at valuing health states that are considered to be worse than dead, parents would prefer their children to live in gruesome health states and be alive. Whereas these youth, when they were answering the questions, I wanted to go, come on now, really? You'd prefer death than living that? But, you know, they were really hardcore, like, nah, I wouldn't want that state, no. And so they were really quite different. Of course, they're young and largely mostly very healthy. So they haven't got life experience in terms of thinking that they'd live in that state. But it does show that the preferences are different, and it doesn't necessarily mean that the caregiver is the right person. It could be someone that they think is a better proxy. And I think that could happen too with people with cognitive disability. And we should be like, I think when we look at these representative value sets, they might be representative in terms of percentage and of gender, age, ethnicity, etc. They're not representative. Even if you've got all the percentages that align with the population, if you've got it through a research company, the people that are in a research company generally, well, maybe a bit different from people who are not. They could be. So we just do the best we can, thinking of all the problems that can come up, but we're kidding ourselves if we think that we've got everyone and it's truly representative. And then there are other studies that do look at things like in New Zealand, there's trauma, like people with spinal injuries. There's lots of studies that try and get health-related quality of life of people in particular clinical areas and track them over time. Yeah.
Hi.
And just
Hi.
to go back to your question about people with developmental disorders, there are, as Paula was saying, there's the proxy version of all the outcome measures. And the proxy can be anybody that knows that person well. So it needn't necessarily be the caregiver, it can be the friend. But there's also an interviewer-administered version for people that aren't able to read the outcome measure themselves or fill it in physically themselves. So there are other ways to get their information and include them.
Hi, my name is Jan Sorensen, and I'm from Health Outcome Research Center in Dublin, Ireland. I just want to come back to this issue with the value set, because in Ireland, there's been quite a long tradition of doing HTA and using the UK value set. And a couple of years ago, there was a new value set that was developed with a protocol that was recommended by the Euroqual group. And that the weighting was very different. The scoring of mental health was had much more emphasis than in the UK algorithm. And then there was an interesting conversation that could be brought up for the technology assessment that had been done. Should all of those be redone and all the ISAs be recalculated? And in a way that, I mean, I took the point that yes, they should be recalculated because now these values are reflecting the local population rather than a neighboring country. But that's quite a big job to do that. And it also creates a lot of disturbances in the health service. So that was one comment. The other comment is that I think I've been involved in OECD work where we have comparing EQ-5D data across a range 11, 12 countries. And the method or strategy of comparing the values is to use the US scores as a sort of generic. And then we also report the scores based on the national value set if they are available. My third comment is that I think there has been done some work, and I think Jan Abel Olsen from Norway has been working on trying to combine certainly the 8 value sets that sort of at a certain stage try to pull those data together into a more international based value set. And my understanding is that it's less sensitive than for sort of small variation. And I think the grouping is a bit cruder than the EQ-5D instrument actually would suggest, but that might be a way forward in sort of having use the EQ-5D in areas where that value set might not be available. Thank you.
Okay, thank you. Again, the participant becomes the trainer. Where's the next question? Here, I think, and then I've lost the order. And then over the we've answered the one that was online. Go ahead, Ian.
So my question is from an implementational perspective. Like some of the presenters said that the survey was sent online and people could fill it, and then I think in India it was more like a conversation, and like how is there any kind of benchmark or standard way to do it, because it doesn't sound comparable if we do it in different ways. And also, like when you send the survey, it's 5 questions, but is there like some sort of footnotes or explanation what is meant? Because just having this 5 questions, I think, is a bit confusing. Like that's my first question. And my second question is about children. So I work in St. Jude Children's Hospital, and we have a lot of patients, but I was like wondering, you mentioned from 16 to 19, what about below 16, like the younger age group? Is there any way to measure their like utilities? Thanks.
Well, so on the survey, whether you do it online or using pen and paper, it is a validated survey in the form that it comes. So you do need to use it as it looks. I have just been saying this at the coffee break. So my long COVID study that's just gone into the field, which is online, uses Qualtrics, and there is a beautifully written Qualtrics module for the New Zealand EQ-5D. And it looks like the paper version. So if you know what the paper version looks like, you tick boxes that are on the right-hand side. So the rest of our Qualtrics survey, all of the boxes are buttons in Qualtrics, and they're all on the left-hand side. And so one of the comments that came back was, why does the survey look different for these questions? And so we actually had to then put an additional screen in that said we are now going to be using a validated, copyrighted survey, and that's why it looks like that. And so it does have to look like it is trademarked to look in that sort of sense. And I think whether you do online or on the telephone, you can do it on the telephone, or you do it in pen and paper, it's just about your environment, your circumstances, and the bottom line, your budget as well, I think as well. Yeah.
I think that's a very good point, because if you go exploring the EQ-5D website and what is available, they've got different versions. They've got a digital, they've got a self-administered, there's got an interviewer administered. So for my case, not everybody in India is educated. Not everybody can read, right? So it's kind of administered via an interview. So there is a huge, I think, 5 to 10 sentences that has to be read out to the respondent before they can go in and ask the questions and fill the questions on behalf of the respondent. So depending on what your mode of collecting the data is, they've got a different version, and you need to get approval to use that version and that kind of thing. So in that sense, I think it's quite systematic. It's quite universal in that sense. So everywhere where an interviewer is going out, you use the same version of the questionnaire for your survey. Yeah. So there is, I think, so that would make it much more neater to administer, and depending on what your mode is. Yeah.
Did you have it? Oh, and children. Yeah. What's the question? What's the answer to that?
Well, there's the youth version. So when I was talking about the study for 16 to 19-year-olds, it was actually valuing the health states. But there's a youth version that you can describe it, and children younger than 16 would be able to describe their health and read them and describe it. But we couldn't be, well, interestingly, I said, what age do you think you could actually trade off health states and think about states worse than dead? And a few of them went, oh, 12 or 13. I thought, oh, not sure about that. But mostly they kind of said around 16 is when you could kind of think about those serious things. But children or young people less than that can actually describe their own health. But it's just like what you're saying there, you could be adults and not be able to read or understand. Janine, you'll be able to, because there's also a youth version.
I'm Jean from the University of Cape Town. I'm a younger population.
Please.
I can answer your question. So we have an EQ-5DY. It's a youth-friendly version. It has the same 5 dimensions and the visual analog scale, but the questions are all asked in a youth-friendly manner. We have a 3-level version, and we'll soon launch a 5-level version. There are about 17 published valuation sets for the youth 3-level version. It currently uses discrete choice experiments from 1,000 general population adults from the country, and then it's anchored on a time trade-off survey from adults. Currently, we're re-looking at that for the Y5L, as there is a lot of talk about nothing about me without me, and they're saying that children's preferences should also be elicited. So that's where Trudy's work is coming in. Can we actually ask children to value their own health? And the youth version can be used from 4 years of age by proxy. Self-complete is recommended from 8 years of age. And then we're also busy developing a tool for infants and toddlers, which is currently under development. So there definitely is a lot in the youth space as well.
And can I just say, it's moved on a lot from when it was the same instrument, but it said play instead of work, and it was in Comic Sans, which just kind of is childlike font. But that's what it used to look like, but it's so much more improved. I think, who is next? Oh, the floating microphones here. Okay.
Thank you. I'm Patrick Atana from London School of Hygiene and Tropical Medicine. Yeah, thank you for the really interesting discussion about EQ-5D. I assume I've never used the EQ-5D, but I'm really interested to see how going forward I can be able to use it in my studies. I work on economics of HIV as well as water and sanitation. From the discussion and my small understanding about the EQ-5D, is a forced choice whereby one has to select. When it comes to analysis, do you consider the how the attributes vary to a reasonable level, or you assume that the attributes, they are on the same level? Because people may put more weights in some attributes as compared to that. So in analysis, do you consider how the attributes vary, and how do you make sure that you don't kind of miss out their variability alongside their attributes.
I'm not entirely sure if I got that, but is it if the adults are answering instead of others that it's not capturing everything? Is that what you were meaning?
Well, so I think
Oh,
Patrick,
good.
if I understood your question, what takes care of the variation is the valuation studies that you carry out. For example, the valuation you carried out in Uganda assigns weights to how people value different health states and then assigns a particular weight. For example, in Uganda, just to be specific, people valued physical movement a lot because the jobs that they do, the majority of the population is manual jobs. They go to dig in the rural villages. Where they get money from digging. So if such a person, instead of being lame and not being able to go and dig, they say they rather die because they know they're going to be alive and suffering. So you found that the largest weight was for physical activity. And then mental health had relatively low. Yet, if you look at other places where mental health is valued more, they'll maybe assign mental health a higher value, like the gentleman said from Dublin, I think mental health had a higher value. And that is the difference why I think it would be ideal to have a value set for every country. Because in Uganda, they will assign a different weight to physical and a different weight to mental health. And in Kenya, they will assign a different, maybe similar, but so that is the work of the valuation studies, because you're trying to get what weights does this particular population attach to different value sets. And then those value sets are what you use when you do another study. You don't have to do the valuation again. You say this population values different health states this way, and then you use the similar weights for different.
So I think we've got two more
Just
questions.
add one small thing. It's not a question. The variability that it's talking about can also be, determined by the disease. If you're doing a specific disease-specific kind of study, you find that, for example, in malaria, pain, will take a bigger weight than probably the ability to move around. And this will be different also for cancers and all that. So I think it depends on different things, the setting, but also the disease that you're looking at.
Well,
I don't know if we are answering.
Yeah, thank you very much. I think, yeah, there's that variability alongside country and setting. But for the individual who are taking the EQ-5D tool, in analysis, do you consider that this friend may put more weights on that, while me, I might put a different, how do you consider that one in analysis now to make sure that?
Yeah.
By the formulation of population for us, randomly, different tribes, different. So it is really done at the time of what the valuation. So different considerations like that. But of course, data is data, can never be counted. You cannot capture those small differences, but you want some assumptions of the
I love it. So that's so there's heterogeneity is I think what you're looking at in the valuation, and you get that if you've got people can have different preferences, particularly across different cultures, and picking up that diversity. But you might have heterogeneity in reporting, which is my idea when I spoke at the start, which is you can use a vignette, so you get someone to complete a hypothetical vignette to say Sally John has these problems, and then you get that individual to then self-report for Sally and John, and then they self-report for themselves. And then if everybody self-reports for Sally and John and for themselves, you can understand their reference, their anchor, and then you can understand whether they're my excellent health. And I use this example, I just want to need to check before I use it. Any Germans in the room? I have a German colleague who claims this is not true, but somebody once told me that Germans would never say their health is excellent. And so when you looked at European studies, you're like, what is with these Germans? They look healthy, but they never say their health is excellent. And that's because they don't use that kind of top category or the translation of excellence into German. It's just not a phrase they would use. So actually, it may be that actually you're not going to use the ends of the scale. And so something like trying to address reporting heterogeneity, you can do that using these anchors. So I think we've got 2 more questions. This woman here and then this man here. You're going to be lucky last. I know you were waiting.
Okay, my name is Nate. I'm from Tanzania. I'm a clinician by background. I'm trying to learn on health economics, particularly applying the EQ-5D for my PhD. I have a question. What is the analytical difference between a self-administered and a research-administered questionnaire? And does it have a scientific or analytical impact if, let's say, the visual analog score is not vertical, it's horizontal, or the variations in administration? Does it really have a scientific or analytical impact? And will you get different results if a researcher administers or someone self-administers the questionnaire?
I'm sure Des can talk about self-administering versus, but the research I think shows it should be the same. I can tell you just one anecdotal story when I was just out of my PhD and somebody had a visual analog scale from 0 to 10. They were trying to measure pain, I think it was, and they only had 7 centimeters on their page. So they made their 0 to 10 a 7 centimeter scale, which literally mean every time somebody marked it, they had to get their ruler out to work out what the translation number was. So yes, it does make a difference. You need to make it look, it has to be a thermometer. And even in the online versions, it does look like that thermometer with the best state you can imagine, the worst state you can imagine. And that is all very important for its validation in that sense, yeah. No, I think with the research around that is that it probably does change the results, but we're trying to minimize the change and trying to make it as small as possible. Yeah. I think ideally we should go with self-administered because it's a self-reporting tool. But if you can't, then it's interviewer administered. Yeah.
But the wording changes. For each question changes. So
the preference, the start of the question and the way that you would say, so rather than saying I have, you would say, do you have? Yeah. Yeah, and there's a script. Yeah, but I mean, and things like that are standardized. But for example, Capel's doing the same. In my long COVID study, I want to ask what their quality of life was, what the EQ-5D was before they got COVID. And so I have approval to actually make it past tense. But again, you go to the office, the Eurocult office, and you ask them for approval to do that. And you justify it and you can get it that way. Final question before we start talking about how do we actually do some more research.
Sure, yeah, thank you. I'm Bijan Bora. I'm what am I trying to say? Yeah, I'm a researcher at Mayo Clinic. So I want to start with qualification that I am no expert in EQ-5D. I use it in my research. So one of the questions that I was thinking about is that when EQ-5D was initially developed, was it not developed for STA? Because that, I think somebody, you mentioned about this, when you apply EQ-5D in an STA context, it's very clean. So what happens is you have a baseline sort of, EQ-5D, you administer a baseline survey. And then after 3 months, 30 days, 3 months, 6 months, you kind of, measure very concrete improvement or, basically, whether a person has improved on that particular scale or not. And it's very clean. It doesn't have any contamination. The moment you kind of jump into population health, you have, I think, Kompol, you were saying, there are a lot of things that might come in, like we may not be able to really control for. So I guess that's, again, I mean, if you can, provide insight on that, that'd be really helpful. And the second question is about Kompal's, I think Kompal and we talked about this morning. India is such a big country, like not just in population, like, we have 22 official languages and about 500 dialects, like, people speak in different languages. So I guess taking 6 states and saying it's an India-based study is not probably appropriate. I would probably, rename it differently. But as you can see, I mean, you go to different part of the country, every 100 miles, you go, literally go into different culture. They would speak different language, different, food, different everything. So that's something you may want to consider. But I guess the other bigger question is more like, what has Eurocall kind of, do they have a guideline when you actually jump to, from HTA to population health? And how do you consider all these different potential contamination that we typically encounter?
We don't have a guideline as such, but we do research on it. So I think my paper was probably one of the first to look at this notion of anchoring vignettes, so reporting heterogeneity, which is now in the EQ-DAFNE. And so the notion is that we've done some research on it and we're still inquiring and understanding if that research exists. I actually think the reporting heterogeneity could exist in HTA, which is the notion that through time, does your reference case differ if you're in a different arm of the trial? Maybe, because you've had a different intervention. And so actually what you might be reporting might not be a clinical improvement. It might be because actually your expectations have been changed from when you're at baseline to your follow-up. So I do think some of these things actually do cross over into HTA. And then
I think you have a point, about the diversity. Sorry. You're right in terms of the heterogeneity of the country and the 22 dialects, and I'm sure Eurocall will be happy to fund me for the rest of the states when I get done with the 6 states. But I think, the fact that it's a huge task to do this kind of analysis, you need to start somewhere. And the way we have designed it, basing it on another study, which has already done the valuation, if I were to propose that I'll do it on all the states, then the question might be, well, the valuations have not only been done for all the states, and there's huge diversity in each state, which there is, and so on and so forth. So I think to keep it neat, it was kind of to follow that same states which were being covered in the previous study. In terms of the representativeness, as I showed, it is somewhat representative on the lines of the other population studies that have been done in India, in the sense that it follows the literacy rates, the socioeconomic background, the SCST, kind of the backward community and so on. But yes, I would say this is just a start from my perspective, to make it in a robust sense to cover as much ground as you can in a systematic way. So yes, but there is a lot of scope out there.
Great, excellent, thank you. I think that's all the time we've got for questions, and I've just got a few slides to kind of cement where you move, how you go forward. Brilliant. I'm actually thinking I'm a bit nervous about my personal conference presentation on Tuesday morning because it's such a vocal group, right? We're going to get some tough questions through this conference unless we've all peaked on a Saturday. And so we've talked a lot about the research that we're doing, which is funded. So how do you guys get involved in that, and how do you get to use the instrument? So how do you use it in a study? So you need to register for use of the instrument, and that's particularly important. Although I'm not sure if anybody's got the time to go through and find out if a study is using the EQ-5D and it's never been registered. But it's a useful source for us as members because we can actually understand who's using it where in that sort of sense. So please do register it. And then they'll discuss the licensing policy, which is, the fact that it can't change. And the idea that it shouldn't be amended, but you can get approval to amend it. So there are studies by members of the group who are looking at the notion of bolt-ons. So asking some of these additional questions, and then they'll review what the wording should be like. So it doesn't, I always think of bolt-ons as Frankenstein's monster, but so it doesn't become something that it's not. So, it will stay as the EQ-5D or the EQ-HWB. And then there's kind of a really neat kind of flow chart. So what's the fee policy? So it's free for use as academics and non-commercial research. So we don't charge a licensing fee at all. We charge a licensing fee for commercial research. So if you work for a pharma company and you want to include it in a clinical trial. If you work for within a healthcare system, so you're a public hospital. I'm not sure if you're a private hospital or they're looking at anybody. They know the answer to that. But it's also I think it's generally no fee for use in a healthcare system as well in that sort of setting. So if you want to include it in the collection of routine data within a hospital sort of setting or in a primary care setting. And then the reason we charge that fee is so that we can support research. And so all the research that's been presented here today has been funded by that. My long COVID study that I'm doing, part of that is funded by the Euroqual. And so they fund study grants, study trips, meetings. So they funded this meeting and they funded some individuals to attend the meeting as well. They fund the working groups and educational materials and white papers. Okay, so it's about advancing the science around the EQ-5D and the measurement of health-related quality of life. And I think, as I said at the start, we're not all singing to the same hymn sheet, if that's an analogy, there is debate within the meetings. And, we're probably almost our fiercest critics sometimes, to the point where it can, somebody suggested the next plenary meeting we attend, it's going to be a little bit of a fight club because we have plenary meetings where the paper is discussed like an oral referee's report by somebody else. And so, it can get quite critical. We try not to let it get personal. But we've also been meeting as groups, twice a year for a number of years. So we do know everybody very well. So we sometimes can get a little bit personal in our critiques. And so it kind of supports all that sort of research. And then there's a whole range of resources. So I'd like to say that we spend a lot of time, I spent a lot of time, these guys spent time doing their slides, but mine were mostly adapted from a slide set that exists. And then when you go to the website, they've even got these great, is it a cartoon? Are we calling them cartoons? Animations, sorry. Like 2.5 minutes. What is the EQ-5D in 2.5 minutes? And so you can kind of follow these animations about what it is. And that can, I think, help you, particularly if you're a teacher. So if you're working as a lecturer, I often use those in my lectures because they're so much more entertaining than me. And all the kind of the references, you can search to see what research has been funded. So there's a database of all the research that's been funded. And then you can think about, because, yes, it does take time to do research and it takes time to publish research, but it's a nice way of searching to see if somebody's doing some work in Afghanistan or Zimbabwe or something like that, the idea of like just to understand who's working in that space. So do have a look at our website as well. And then that's it from me and from these three. I feel like I'm in a two Ronnie's sketch now. And also I'd really love to thank you all for taking part, being so engaging and asking critical but inspiring sort of questions. And I look forward to having chats with more of you. There is we do have local meetings. And so we've had a African Euroqual meeting here last year, and there is supposedly going to be one planned for next year. So for those more local to this continent, I don't need to fly 30 hours again to come here for a meeting, not that I'm not enjoying it so far. Then we can do more of that kind of research here. And then we also have I think an Asia meeting as well. We're doing more kind of local meetings because it's also much more sustainable as well. So thank you very much, and look forward to seeing you on the next few days of the conference. Thank you.